morning. I would like to first thank Dr. Selva sir, DPH, and his entire team for inviting me to be part of this event. Next 10 minutes, what I would like to do is to, in a sense, recollect our experience during 2017-18 when Government of Tamil Nadu Health and Family Welfare DPH department piloted the universal health coverage scheme in 3 blocks in Tamil Nadu in 3 districts. So in a sense, I want to use that positive experience as illustrations of our attempts. When I say our, I mean the government. Are you okay? Our experience, meaning our government's experience in introducing digitization at the very ground level. So, both the previous 2 speakers and some of the speakers yesterday highlighted the importance of big data, how it can be used across the spectrum of research to health delivery system. But I want to drive home today using those 2-3 illustrations is that eventually we have to see, I'm speaking from someone interested in exploring ways by which the delivery system could be, the effectiveness of the delivery system could be enhanced in public system. So eventually it should help in enable introducing more grounded interventions in achieving public health policy goals. Okay, so I will revisit this statement at least 3 or 4 times after every illustration. Okay. Next. This is in a sense a summary of, again, the previous speakers and some of the speakers yesterday. Without going into every one of these, I want to look at the last part, the point 4 on value, the quality. If you read that, first 2 lines, ultimate goal of harnessing big data in healthcare is to derive actionable insights, that is, insights that will help the program designers and implementers to design or redesign, introduce public health measures that will improve patient outcomes, enhance operational efficiency, reduce costs. Okay, this is a summary from the paper that I've given, but that's our focus. The next few minutes, I'll give 2 examples of what we tried to do in the pilot blocks 5 years ago. This next 2 slides, I'm going to show you RBS values of patients who are under medications for diabetic from the 3 blocks, a small cohort, and very interesting observations and leading to potentially effective interventions. Just look at 1 or 2 things I'm going to highlight. Don't look at everything there. It's a pointer working? Sir? Pointer is working? No? Okay. Pointer is not working. So, look at the table. It gives a summary of, in a sense, that I have chosen a cohort of 62 patients whose values were obtained on random RBS December 2017. The same 62 patients, they were all supposed to be regular patients, in the sense who were followed up, were taking medicines, over a period of 6 months. And we plotted the 62 patients' baseline data, 2017, in the ascending order. And we have given a threshold level of 200. Anyone above that as classified as diabetic, and below that as not so. So the blue line is, each dot is a patient. RBS value 2017 December, and the corresponding value of the same patient measured in June 2018. So what you see there on the first quadrant, left northwest quadrant, the orange value shows for the same individuals a much higher RBS value compared to their base year. So that's clearly you can identify each individual, who they are, which village they come from, with the household address as well. Thanks to an application software that we used, based in Tanjavur then at that time. So we can actually identify whether they are from the same village or same streets or contiguous areas, villages. What you see on the northeast quadrant, many of them have had a value, the blue dots, higher than the values measured in 6 months later. So they've all shown, in a sense, improvement. So that's very good. So we can even take lessons from them. They were complying with the drugs prescription. What else they were doing? How they were able to maintain and bring their values down. So what I mean by actionable step following such observation is that, and we have a similar data for a shorter period, a different cohort from the pilot, you get the same observations. But on the northeast quadrant, you see many more patients whose values are higher, both in the baseline as well as later years. How do we move forward? Is that, as I said, each dot is an individual. Each dot is an individual from a village or a street. You can actually zero down. The big data should be able to zero down who are they at village level and what next to be done, particularly for the northwest dots. Maybe they require more counseling. Maybe we need to understand their lifestyle behavior changes, which is making their values go up. That requires complementary interventions in terms of health promotion activities, counseling. So the data should enable initiating counseling and health promotion in areas where it requires intervention. Not so that your resources are also spent more effectively in dealing with those clusters where counseling is required most. So this is one illustration. So you can have for each block, there are 400 blocks presumably in Tamil Nadu. Each block you can, using such software, track every patient who are in your line list every 3 months, whether the values are going up or down, same cohort over a period of time. So your review meetings becomes more informed, leading to suggesting, demanding more resources for promotion activities, and therefore the allocation of resources also become more rational. Next, this is a little more complex, but nonetheless, using the same app, in the same pilot area, we plotted the blood pressure value of individuals of nearly, the sample is about 10,000 observations. So some of them are repeat patients. So what you see here is distribution of individuals whose values were above 120 or above 80, below 120 or below 80 and so on. You can divide that into 4 quarters. So how is it helpful? So if you take that dot on the northeast, topmost, northeast, there's a blue dot there, much above 80 and much above 120. When zoom down on that individual, who is that individual? What were his values the previous 4 or 5 times when he visited and his values are observed? And all such dots around that individual, are they all from the same villages, same community or contiguous areas? Leading to again the same observation that I made in the previous slide, that designing specific health promotion activities and counseling. Now this kind of simple illustrations also tells you about something very important, about the quality of data. So this is a cohort nearly about 5,000. What they did was, all the values they rounded off. So if the value was 127 by 76, so they'll round it off 130 by 70 or 75. So that's why you find the cluster here is very different from the previous ones. These are all actual values. These are rounded off values. So we can even go back and even train the VHNs who have entered this data not to round off the values. Okay, so it tells you a lot about the quality of such digital data as well. Leading to the same observation that I made a while ago. The third example is something that I want to speak, we can have a separate session on that, but I want to just highlight one simple thing, that we all have are sitting on huge secondary data, particularly with respect to maternal health and who's had ANC 1, who has had 2, 3, 4, 5, and you will see the trend in ANC 3, how it falls. But that everybody knows. You can sit here and do that. But what is the actionable intervention following such? I want to make 2 points here. That every BMO, when he or she has a regular review meeting, okay, she's not able to pull up the data from the back end, look at the trend of a cohort in her block. She may have all that in her mind. But just imagine a new BMO who comes, it will take quite a while for her. So that's why such empirical presentations are important. But more importantly, you can also look at the quality of the program by looking at every single diagnosis that is supposed to be done for every woman who is coming for an ANC visit. You'll find some of them missing, some of them there. Okay, so you can talk about 2 things, quality of the care and quality of the data as well. Many times care is given in a good quality care, but you find data missing. So you can talk about both why the data is not there when you inquire into it. It's not because care is not given, it may be because of other workload they are not doing it. So there's a lot that we can do here. I will just highlight this point and move forward. Just almost my last slide here. So I'm very glad to see Dr. Kannadasan and Dr. Balla present here. I didn't know they would be here. I'm very sure later today they will be talking about their ECHO project in Tamil Nadu. But I read the New Mexico experience as part of a book that I was reading, where they have introduced what is called telementoring, as I understand from that case study, which is going beyond telemedicine, where the AI actually sits between the physician and the patient, listens, synthesizes, and derive some general observations from across thousands of such conversations, which could be helpful for harnessing AI. There is also another experience called Tattva Care, where we all have used PubMed, searching for articles on diabetes in South India. Last 5 years, it will spit out something. But it goes one step beyond, can ask specific questions, and it will review the literature and gives you what is the state of knowledge. That's something becoming common, we are all becoming aware of. And again, due to lack of time, I would not spend much time on this, which is becoming very, very important in building digital public infrastructure, of which healthcare is one such. So let me conclude in a way that big data in healthcare, there are a lot of expectations. Many people have highlighted how it can help in fundamental research to healthcare delivery. But what we need is the bottommost fourth one. As someone interested in implementation research, I'm not saying this is more important than the others, that from my engagement with the healthcare system here, we need more information in a digitized form on population health, if we wish to make informed intervention in order to enhance the delivery system. So the bottom line is, let us digitize in simple incremental manner, as we have demonstrated even 6 years ago as part of UHC pilot. And it is very much doable, while other efforts can go on. So I'll stop with this. Thank you very much.
So thank you, sir, for giving us a brief thing about all the importance of a data. Because when we are students, we've been taught about what is a data. Any data gives us some information to us. So with this, we are given the usage of the big data analytics with 3 best examples of RBH and hypertension and PNC, what we have. And what I feel is, we are the people who are generating the data. So we should understand the importance of a data and how it is being useful both for the patient perspective as well as the government policy perspective. And any queries from the audience, or any clarifications, or any? Sir has explained with all the 3 pilots what we have done in Tamil Nadu, the Virali project, all the 3 projects. So it is a data which we have done, and he has analyzed and he has given what is the factors involved in those things. So we, as a district health officers, we should understand the importance of data, what we are creating, which will be useful for our policy decisions also. So, thanks a lot, sir. Thank you.
Thank you very much.
Thank you for your presentation, sir, and we apologize for the technical glitch. So it's a privilege to once again introduce our speaker, Dr. V.R. Muraleedharan. He has interest in research, include healthcare economics and health policy. His research focuses on evaluating the equity and efficacy of investment in Indian public primary healthcare system, particularly the implementation of universal health coverage in Tamil Nadu. He holds a master's degree in economics from Plenary and a PhD in the healthcare economics from IIT Madras, a Takumi Fellow and postdoctoral researcher at Harvard University. Currently, he leads the Center for Technology and Policy at IIT Madras. He serves as nodal person for the Tamil Nadu Operational Research Program under Tamil Nadu Health System Reform Program. Thank you, sir. Now I would welcome Dr. Satish Raghavan, sir, JD TANSAC, to felicitate the speaker. Thank you, Vinay, sir, for